I'm going to ask Dr. Cesario to come up shortly and present his program to you. I would like to thank you, Dr. Cesario, for being here. I have lots of positive feedback from all the doctors that I go to that say you're the best. So Dr. Cesario is associated with UC Irvine. He's a retired dean of School of Medicine over there, and so he comes very well. Highly recommended. So I am going to introduce Dr. Cesario, and if he would like to take a minute to just tell you about himself, that would be great, and then we can start the presentation.
Ellie, I think you've told everybody enough about me. I've been at UCI for well over 40 years and have been in the infectious disease division over there. What makes coronavirus a little bit different than other viruses is not so much in the nature of the virus, because this virus has a nature really very similar to all the other viruses that we know. What makes it problematic for us is that we as a human population have never seen it before. So we are vulnerable to it, and we are uniquely susceptible to it. And for that reason, it has spread through the human population like wildfire. And as you know, we're now close to 2.5 million people in the world been infected with this virus. It's similar to what happened when diseases like measles and chickenpox was introduced to the Indians during the 16th and 1700s. They, again, a very vulnerable population that hadn't seen those diseases. And when they were struck by them, the diseases spread rapidly through the communities with a very high mortality rate and wreaked devastation. So it's the fact that we are so vulnerable that makes this a special problem for us, and in some ways a catastrophic problem. So here's a little scenario of the viruses as we know it from the past. Coronaviruses are not new to us. They actually were discovered originally in the 1930s as diseases of chickens. And you have to remember in general that the whole field of virology is relatively new to us, because we knew about viruses going back to the late 1890s, but we really didn't know how to grow them. In fact, when we had the major influenza epidemic of swine flu in 1918, 1919, we had never grown the virus. The virus was not grown until 1933. So it's only been since the 30s that we have begun to develop some rudimentary understanding of what viruses are and what they do. And then with the discovery of tissue culture, which is a way of growing cells in a test tube, we literally were able to begin to explore the world of virology more seriously. And from that, there came the discovery of a lot of viruses, including an additional coronavirus. As you see, the mouse hepatitis virus was discovered in the 40s. And then really, I would say in the 60s, when the era of molecular biology and molecular virology came into being and became to be exploited, then the whole world of virology exploded, and we were able to learn enormous amounts from it. And now we rely, I would say, even more on the techniques of molecular virology, as we'll talk about when we talk about the diagnosis, than we do about a standard tissue culture. Although the standard tissue culture still remains a cornerstone of the world of virology and critical to our understanding of the viruses and how infectious they are. We know from the 60s that the first human coronaviruses were discovered. We'll show you in a second a slide of what they are, but those viruses were common respiratory viruses, 4 of them in all, and most of them were fairly benign, common cold viruses, probably account for somewhere between 10 and 30% of the respiratory disease, common viral respiratory diseases of adults. We don't know when those viruses were introduced into the human population. In fact, they may have been introduced in the same catastrophic manner of this virus, the one that we're talking about now, SARS-CoV-2, in a period long ago before we really knew what viruses were. So all we know is that the viruses, those other viruses today, seem to be relatively minor respiratory infections. All in all, we know that this class of viruses that we call coronaviruses is a category that includes about 30 different viruses that we know of, most of them viruses of animals, particularly pigs, camels, mice, and particularly bats. We'll talk about that a second because two of the major categories are in fact categories that are largely confined to birds. So this is a picture of what the virus looks like. And this is not at all unique in the world of viruses. I like to think of them sort of like a biological walnut. They have a shell, which in this case we call the envelope. And you can see here it's the orange, at least on my slide, the orange lining of this virus. And from it, there are a number of projections that we call the spikes, spike glycoproteins. Very much like influenza virus and a lot of other viruses. The spike is what allows the virus to attach to a cell. And you have to remember what's different about viruses, unlike bacteria, that you can grow in an artificial media. Viruses can only grow in cells. And their tropism, their affinity for certain cells is very specific. And the reason it's specific is because viruses have to attach to a specific receptor. It's like a lock and a key. If the virus doesn't have the key, it can't unlock the cell and get in. So that relationship between the viral spike and the receptor on the cell is very specific. For that reason, a lot of the other animal viruses that we talked about a second ago can never infect humans, at least in their current state, because they don't have the right component, the right spike to attach to a human cell. So that's this very specific relationship that we're going to talk a lot more about. Also, probably our immunity results from the development of antibodies and other components of our immune system that are directed against that spike. So if you develop an antibody that covers those spikes, then you effectively neutralize the virus. And that's one of the things we are working on now as a potential for treatment. So that's the spike on the surface. You see the envelope. Inside of the virus is the pink staining material are the viral genes. And they are surrounded by protein that we call the nucleoprotein, which protects the genes and also regulates when they're going to be recorded or when they're going to be analyzed or translated, or when they are going to remain silent. So the virus exists in this form with spikes on the surface, a shell that we call the envelope, and then the genetic material on the inside. In the world of virology, there's only cells that have either one type of genetic material, which would be like DNA, that would be the herpes, the chickenpox viruses, or RNA. And in case that would be like the coronaviruses, polio viruses, influenza viruses, all have RNA. We as humans have both, DNA and RNA. But viruses have one or the other, but not both. So if we dissect the genes, if we take that genetic material out from inside the cell and we look at what is in it, what does that genetic material do? What is it recording? And these are schematics of the earlier viruses in the family. One, the SARS-CoV-1 from 2002, 2003, and the other, the MERS virus, Middle East Respiratory Syndrome virus, which was discovered about 2012. But they show the same thing. They show that the genes are actually very simple. Remember, we think as humans, we have about 33,000 genes, something in that category. Here, these viruses only have a few genes. They code for 4 structural proteins. They code for about 16 proteins, which are important in the replication of the virus, and 4 to 8 accessory proteins that we don't completely understand what the function of all of them is. We know that the first half of the genetic material is all devoted to genes that will help the virus copy itself. And the last half of the genetic material, beginning with the pink S of the upper SARS-CoV virus, are the beginnings of the structural proteins. Those proteins that will actually give the virus the shape that will ultimately look like the walnut that we just saw on the last slide. So this is what the genetic material of the virus looks like. Very simple. You would think more than once, how can something this simple be so catastrophic to humans? But there it is. Now this is the life cycle of the virus. And it looks like it's a little complicated, but I'm going to try to dissect it. Why is this slide critical to our understanding? It's because this is how we design the drugs to try to kill the virus. This is how we design those treatments to try to interfere with the virus life cycle so that we are able to destroy or inactivate the virus before it makes us sick. And I always like to point out a comparison with AIDS and HIV virus. I point out that almost all of the HIV drugs that we have today, and I remind everybody today, if you have been infected with HIV virus, you received effective treatments, we basically can give you what looks like a pretty normal lifespan because of the drugs. And all of those drugs have been developed because we've learned the life cycle of the HIV virus, and we've been able to predict where we can interfere with the replication of the virus without doing damage to us as the host. So the life cycle becomes very important to us. So let's look at the life cycle of this virus. You can see in the upper left-hand corner of this slide, the little round circle there with the spikes on top of it is the virus beginning to enter the cell. And you can see the spikes have attached to the surface of the cell by a specific receptor, which in this case is called the angiotensin converting enzyme, ACE2. It's an enzyme very similar to one of the enzymes that are important in our bodies in regulating our blood pressure. In fact, we have whole treatments now that are drugs that block angiotensin converting enzymes. Unfortunately, those drugs work on a slightly different enzyme than this. So this virus attaches to the angiotensin converting enzymes in the respiratory tract. That begins, of course, in the nose and the throat and all the way down into the lungs, all the way down into that part of the lung where we actually exchange oxygen between the outside and the inside. The air circulating in the air and the blood of that brings oxygen to all the vital organs of our body. So the virus attaches, and then it's got to find a way to get in the cell, and it does that by a process literally called invagination. That is, it pushes its way into the cell, and the cell membrane, as it pushes its way in, kind of surrounds the virus. And so it surrounds it in a little container that we call a vesicle. Again, a little analogy to a little balloon that the virus is inside of. Now, when it gets inside of that balloon, then in order for the virus to get into the cell itself, the internal pH, the acidity of that vesicle has to begin to change, has to become a little more acidic. If that does not happen, the virus cannot release its genetic material into the cell. So that acidification process becomes important. And as it does, it allows the membrane of the cell, the envelope of the virus, to actually fuse with the membrane of the cell that surrounded it. And that eventually allows those two membranes to open up and allow the virus to pass inside the cell. Now, remember I told you that's very important for the inside of that vesicle that we call the endosome to become acid. And when we talk a little later about working on drugs that may interfere with this process. We'll talk a little bit about chloroquine and hydroxychloroquine. That's the malaria drug that has gotten so much press. What that drug does, it interferes with the acidification process inside the cell. So it helps to prevent that from changing enough that will allow the virus to enter the cell. At least it does that in tissue culture. We don't know whether it does that yet in people, but it does it in tissue culture. So it prevents, in some way, those steps that allow the virus genetic material to enter the cell. Now, when the virus genetic material does enter the cell, it has to begin the process of taking over the machinery of the cell to turning out new virus particles. And in order to do that, it has to do two things. First of all, the new virus particle, like the old ones, is going to have genetic material, and it's going to have to structural proteins, and it's going to have accessory proteins. And the map, the architecture for that, is all inside the genes of the virus. So among the very first things that has to happen for the virus to allow itself to reproduce is it's got to copy its own genetic material for the future viruses that are going to be released. And it does that by beginning a process which initiates, it's actually initiated by enzymes that are already in the cell that allow the viral enzyme to copy itself to allow it to reproduce new viral genes. And that enzyme from the virus itself is called the RNA-dependent RNA polymerase. That's another enzyme that we think we can block. And we do that, blocking those polymerases, for example, in the treatment of hepatitis. We know we can effectively block the polymerase of hepatitis C, and we treat the virus. So we are looking for drugs that interfere with that RNA polymerase. And one of them we'll talk about later is remdesivir, and that's what remdesivir drug does. It blocks that enzyme from copying the viral genes, and in so doing, it prevents the synthesis of new viral particles. So we first get a map, a form to copy the virus RNA. We get copies of the viral RNA, and then from those new copies of RNA, we begin the process of synthesizing all those proteins that are necessary to form what will be the progeny viruses. And as those new proteins are formed, they stick into an existing component of the cell called ER, for endoplasmic reticulum. They stick on the surface of that, and they await for the replication of that new viral genes, literally to poke their way into the center of what now is going to be a new vesicle. And that vesicle then is transported through a series of tubes that are inside the cell that we call the Golgi apparatus, and they move to the surface of the cell where they are released to the outside world. And so a new virus coming into the cell copies itself, and in many cases, I don't know what the exact number is for the coronaviruses, but one cell that gets infected by one virus could potentially release 1,000 new virus particles. And that's how the virus keeps replicating, goes on to the neighboring cells, the neighboring myriad of cells, and you get more and more infected cells and more viruses until the body is able to eventually try to control the virus by the development of some components of the immune system that can neutralize the virus. This is an electron micrograph of the coronavirus, SARS-CoV-2, actually attaching to a human cell. You can see that the orange virus particles actually look pretty much like the schematic. And we call it coronaviruses because those little spikes on the outside give the virus the appearance of a crown. And corona, the Latin word for crown, also the Italian word for crown. So we call it a crown virus, the coronaviruses. If you remember a long time ago, Linnaeus gave us a classification system for all living things. And so just as with plants and animals, we classify viruses. And this is a slide to show that these viruses are classified like everything else. You can see there are 4 subcategories: alpha, beta, gamma, delta. The alphas, which include other viruses than those listed here, are 2 other human viruses, 229E, NL63, discovered in the 60s, and actually NL63 was discovered about 2000. They are the ones that cause common respiratory illnesses that are rarely of a significant degree of severity. The betas include 2 simple ones from, again, OC43 from the 40s, and another one discovered in the early 2000s in Hong Kong for Hong Kong University, HKU1. And now we have HK1, 2, 3, and 4, which again, simple respiratory viruses, not causing a lot of severe disease that we worry about. And then we have SARS-CoV original from 2002, 2003, SARS-CoV-2, which is what we're dealing with today, and the MERS virus, which is the Middle East Respiratory Syndrome virus discovered in 2012. The gamma and delta virus categories are basically viruses of non-humans, particularly birds, and don't, at least so far, seem to pose a problem for humans. So what are the other viruses that we have had to worry about before? Well, the first virus that we had to worry about was the original SARS-CoV, period. And that emerged in 2002, 2003. It emerged from China, was known particularly to be a virus that had been isolated from an animal called a civet cat. And for a while, it was thought that maybe that was what the origin of the virus introduction into the human population might have been. But then it was realized that the civet cats themselves had been infected, and that they had in fact been infected from bats. In China, as all of you know, there is a variety of meats that are consumed for human purposes that are not necessarily those that we would that are those that are grown commercially, but are harvested from the wild, essentially, or at least are derivative of wild animals, and so they have an opportunity to be exposed to things that we might not otherwise be exposed to. And just to divert for a second, this is a problem for us in this day and age, because we know there are parts of the world where viruses exist among animals, possibly birds or a variety of other animals, that we as humans have not seen before. And for whatever the reason, either by virtue of development or by virtue of accident, we get exposed to those. And if the right circumstance happens, and those viruses have the right key to a receptor in our bodies, they have the potential to infect us and do the very same thing that coronavirus is doing now. And have we seen that before? Well, we saw that with Ebola virus. We saw that with Zika virus in the last years. So we know that this is possible, and it's going to happen to us more than once. So it was the same with this virus. It was probably introduced to civet cats, and in that process, it changed just enough that the spike protein was able to adapt to human cells, probably by some slight mutation or recombination. We'll talk about that in just a minute. And suddenly, the key was able to unlock the human cell. So this virus then spread rapidly, largely through China, affected, as you can see, a little over 8,000 people, 26 countries. Not entirely sure how many countries it was infected, but somewhere between the 26 and 30 had at least documented cases, and resulting in the number of deaths, 774 deaths, so roughly a 10% mortality rate. And in the US, we had 8 cases. And then all of a sudden, the virus disappeared. We don't know what happened to it. We don't know where it went, but it just suddenly stopped infecting humans. And for practical purposes, we stopped worrying about it. The interesting thing is that virus has the very same receptor. That is, the key to that virus unlocks the same lock in our system called the angiotensin converting enzyme 2. This is the Middle East respiratory syndrome. Out of Saudi Arabia, we became aware of another disease, again, largely pneumonia. And that's what the original SARS-CoV virus did. It was a pulmonary infection, an infection of the lung. And so it was with the Middle East respiratory syndrome. But a very significant infection of the lung, largely seen only in the Middle East, with rare cases outside of the Middle East, almost always in travelers from the Middle East or Middle East residents who had gone outside the country. It was found that the virus actually was present in camels. And for a while, we thought maybe it was a camel virus until we appreciated the fact that it too had originated from bats. So like SARS, which had gone from bats to civet cats, this went from bats to camels to humans. Again, changing just enough along the way that it could adapt to humans and spread. So it infected 27 countries, about 2,500 cases, with about 850 deaths, 858 deaths to be exact, 2 cases in the US. This virus, unlike SARS-CoV virus, has not disappeared, but it hasn't exploded. It has stayed largely in the Middle East and just kind of simmers along. A few cases here, a few cases there, never gone away, but never really burst into the human population like SARS-CoV virus 2. It has a little different receptor, an enzyme called untitled peptidase, but the process of replication is all very similar. A lot of correlations between this virus, the original SARS-CoV virus, and the virus that we have today, which is SARS-CoV virus 2. So this is SARS-CoV virus 2. Now we point out, we call the disease COVID-19. The virus is SARS-CoV virus 2. So COVID-19 is the name of a disease. So SARS-CoV virus 2 actually emerged probably in November of 2019. And when we say emerged, what that really means, that's when we recognize the first case. It might have been there a long time before that. We just didn't know about it. It might have been there as a slightly different virus, suddenly changed a little bit, whatever. But we think the very first cases were probably in November of 2019. It became apparent that it was spreading in China in December and then exploded in January. And the first cases became apparent in the US and Washington, state of Washington. Sorry about the lack of an N there. I tell everybody that I'm told that in the Middle East, in the Muslim world, when they make a rug, they always make sure they put one mistake in it because only God is perfect. So I want you to know this is my mistake. There's no N on the Washington there. January 19 was the first cases in the state of Washington, and then it exploded. And what was a very catastrophic event in Washington is that it got into a nursing home with, I think, 450 odd residents. And before they were done, they had a large number of cases, I think 83 in all, with something like 23 deaths. So that was the first time we became aware of the potential that this virus was spreading in the US. And from there, it jumped to one state to another until now we have it literally in every state. It too is a bat virus. Because it's a bat virus, we tend to think like we did about SARS-CoV virus 1, Middle Eastern respiratory syndrome. Was there an animal link between the bats and humans? And we don't know exactly where it is, that we think it's very close to a virus isolated from an animal called the pangolin. Again, an animal that is used for human nutrition in parts of China. It is, I think, in some cases raised, but it's certainly hunted and used for human meals. And this slide is what the pangolin looks like. It looks like a cross to me between an anteater and an armadillo, but it's the only mammalian product, only mammalian, only animal, only mammal that has scales. And you can see the scales here. It's an anteater, oddly enough. And it's about the size of a cat. That's how it looks. And we know that the human SARS-CoV-2 is very similar, I think about 96% similar by its genes to a virus isolated from pangolins. So it's quite similar. And right now, many people believe it's the pangolin that was the intermediary between the bats and humans. So here's a SARS-CoV-2. Really is very similar to a lot of other viruses that we know of. Its genes are made of RNA, ribonucleic acid. It's a moderately large virus. To give you an idea, influenza virus is about 120 nanometers in size. It has a RNA that's the largest RNA in terms of its length of any RNA viruses that we know of. Its genes are very similar to SARS-CoV virus, the original virus. I always like to call it SARS-CoV virus 1, but its official designation is SARS-CoV virus period. About 80% of the genetic material is identical. Its genetic material is a single strand of RNA. You know, like our DNA is double-stranded. In this case, the RNA is a single strand. We call it positive sense, meaning the blueprint for the virus is already there. It doesn't have to go through a 2 or 3 step process of changing it. It can be read directly from the RNA to make, goes through an intermediate state, but makes a new human virus. It has, as I told you, it has about 4 structural proteins. It has about 8 accessory proteins and or non-structural proteins, and another 4 to 8 accessory proteins, all of which we're trying to figure out exactly what they do. We mentioned before about the major structural components, the spike, the membrane, the protein that covers the genes, the nucleocapsid, and the envelope. Why do these viruses seem always to come from bats? What's unique about bats? Well, we know that there are about 1,100 bat species in the world, and actually, for the most part, they render a very important function to us as humans. They consume a lot of undesirable things, insects, and their place in the world is important. And so were we to destroy all of the bat species known, despite their appearance, we actually would do harm to the world as we know it today. We know bats carry other viruses, chiefly of which is rabies. We know a lot of human cases, including some here in the US, have been directly the result of bites of rabid bats. There's a couple of other Middle Eastern viruses, Hendra and Nipah viruses, which are known in Australia and in places like Indonesia. And also, we think Ebola and Marburg, the cousins, we call them filoviruses, probably also originated from bats that infected probably primates. And from the primates, they infected humans. What about bats? Why are they a problem for us? Well, they exist in large colonies, oftentimes in groups. And inside the colonies, there are oftentimes different species of bats, and sometimes with their own viruses. And they particularly seem to harbor coronaviruses. So in a given colony, particularly like in caves, where there may be literally millions and millions of bats, different species, different types of coronaviruses, all circulating either within certain species or multiple species, none of which have exactly the right capability of infecting a mammal and then being transferred to humans. But we also know that those viruses that as of yet can't infect humans through probably a process of simple changes, some of which may just involve mutation, some may involve two of these viruses getting mixed in the same cell and coming up with a new progeny virus that is just different enough that it can begin the process of infecting mammals or other animal species. That process of the two combining and coming up with a new virus is the process we call recombination. And we know coronaviruses are very capable of that process. Furthermore, when you have all of these bats in a cave and they are eating, as they all do, and forming excrement that we call guano, we know that the coronaviruses can be isolated from the droppings in those caves. That means mammals coming into the caves, possibly humans at some point. Could be, if the right circumstance exists, the virus has changed just enough, inhaling that material from those caves would be just enough to introduce the virus into either mammalian species, possibly into humans. And we know that the bats, when they carry this virus, unlike humans, where we get the disease and get over it, they can carry the virus for long periods of time. They don't get sick with it. They don't die from it. They just carry it. And that also is not unique to us. We know that happens, for example, with some of the hepatitis virus or the AIDS virus. You can carry it for long, long times and still be okay with it. And that's what happens in bats. So we know that these viruses, as they exist in the bats, are capable of change one way or another. And it's through that change that it is likely that sooner or later, one of those changes is going to result in a virus that now can infect animals, and animals can then be the vector by which it infects humans. And it has been predicted before that this was going to happen before, that we were going to get another epidemic of SARS, and it likely is going to happen again. Whether it will be 10 years, 50 years, 100 years, you can't predict, but the stage is set for allow that to happen again. So the next slide is a little bit about the virus. So what do we know about this virus? And what I want to say is how infectious is this virus? When I talk about how infectious it is, I want to talk about three different things. What do we know about humans getting infected? What do we know about the virus itself? How long it stays in the throat, how long it's viable, how long and by what means can it travel to others, and what happens in the environment to the virus if it gets out. So we think when this virus infects humans, it's largely spread by droplets. Now, what does that mean? That means that when you cough or talk or sneeze, you expel a certain number of particles out into the air. And there are a whole spectrum of sizes, from very tiny ones to larger ones. Droplets are 5 microns or larger in size. Usually that means it's a little fluid particle, a little bit of a saliva, let's say, or a little bit of sputum that contains maybe as many as 1,000 virus particles. And that little drop of sputum is too small for you to see or barely visible. And it contains a large number of virus particles. If they're in particles of 5 microns or larger, they likely will settle out, drop to the ground within a very short period of time, and no longer be possible to be inhaled by the next person. If they are smaller than that, particularly if they dry out, then sometimes they can remain suspended in the air and travel for large distances. So what do we mean by that? In general, we think that most of the time you get infected by SARS-CoV-2, that it's infected by these larger fluid-containing droplets that settle to the ground. So that if you are more than 3 feet, and we say 6 feet to be sure, you are likely not to inhale particles from a person in the room who's infected. But you get inside that area, particularly inside 3 feet, you are likely to inhale that particle and in so being infected. We also know that the virus doesn't remain viable for extended periods of time. We know that on surfaces, depending on the nature of the surfaces, plastic, for example, stainless steel, it lasts longer, probably as long as 3 days. And in certain circumstances, if the conditions in the air are right, it could last longer than 3 days. On cardboard, probably lasts 48 hours. On other surfaces, it may be 24 hours. But in general, we say that on surfaces, the virus can exist for several days, and you have to be aware of touching surfaces, because besides inhaling it, you can get it on your fingers, and if you rub your eyes, if you rub your nose, if you rub your mouth, that may be just enough introduction of the virus particles to get inside you and begin the process of infecting you. It's easily inactivated by alcohol, 70% alcohol, hydrogen peroxide, and diluted bleach, 5 tablespoons in a gallon of water. And that inactivation process is very rapid, probably less than 30 seconds. So that's why the alcohol hand wipes and surface decontamination with the dilute bleach are very effective in killing the virus. Soap and water is also very effective. If you get it on your clothes, just put it in the washing machine, and that washing machine cycle will kill the virus. Fomites just means inanimate objects which contain, or upon the surface of which is the virus that you can pick up. So we know that fomites are another way of allowing you to touch their surface, and so doing carry the virus to your respiratory tract. So let's now talk about humans. What do we know about how easy is it to get the virus? Well, we know that from a lot of studies that have been done, that the reproductive number, and what the reproductive number means is if you have the virus infection, how many people are you going to transmit it to? What is the average number of people you will infect? And there are a range of different studies from as low as 1.4 to 6.49. One investigator averaged it, said it was 3.38. Most people say today that it's somewhere between 2.2 and 2.4. So if you think of this, if one person gets it, on the average, they're going to infect somewhere between 2 and 3 other people. And so that's an idea of how infectious it is. How does that compare to other viruses? Most infectious virus I know of is measles. For measles, that number is 12 to 18. For influenza, we say 1, but that's, I think, a misnomer because most of us have some partial immunity to influenza already. And it's only when we get diseases like Asian flu or Hong Kong flu that you see the true infectivity of influenza, which I think may be closer to 10. If you live in the same household of somebody who comes home with the SARS-CoV-2, the likelihood that you are going to get it is somewhere between 3 and 10%, depending upon how close contact you have. And in one study, actually it was closer to 15, in some cases I think even 20%, if you have a lot of very close contact with that person. In the report that was given from China with an unknown investigator by the name of, and that person said in their study of household contacts, 15% got it, and of contacts less intensive than the household, it was roughly 10%. So the picture that we're trying to create here is that if you are in close contact with a person who carries the virus, you are likely to get infected to the range of somewhere between 10 and 20% with close contact. So that means, in my opinion, it's definitely infectious, not as infectious as some of the other viruses, but with little breaks in technique, little things you forget to do, becomes that much easier to transmit it. Can you interrupt that transmission? And yes, you can. We'll talk a little bit later about things like masks, etc. Certainly hand washing to prevent acquisition from the surfaces. Maintaining distance, social distancing also matters. Just want to point out that it is quite infectious despite what I said, as long as you're in fairly close contact with somebody. So here is a list of about 10 circumstances. They all happen to be, with one exception, places in China, where people largely were in a meal together, in close contact in a home. And a number of people happen to be exposed. And you can see when you get in these closed circumstances that a number of people do get infected. And in fact, it's a significant number of people who get infected. And so in circumstances where there are tight surroundings, I like to say a single room with a lot of people, chance of acquiring the virus becomes substantial. We now know there are a number of circumstances. Getting a lot of press right now is a little town in Germany called Gangelt. And in Gangelt, somewhere in February, there was a big town hall celebration. I think it might have been just before Lent. It might have been something like Fat Tuesday, where the individuals were grouped in a very small room, 300 people, with a lot of hugging, a lot of kissing, a lot of drinking. And from that, a substantial number of people were infected. And today in that city, 15% of all the people have been infected with the virus. We know a similar circumstance in Australia and in France. So it's in those closed circumstances, a single room with a number of people, one person brings the virus in, and it's potentially an explosive spread to other people. Now, what does this slide say? So when I talk about infectivity, I talk about first, what do we know about how people get it? But the second thing I want to know is, what do we know about the virus itself? Where do we know where you can find it, how much of it is there, and what happens to it? And these next few slides were a series of patients taken when we were studying the virus by detection of its genes. And there's a simple way to do that. We call it a PCR, polymerase chain reaction, reverse transcriptase polymerase chain reaction. You can detect the viral gene. And for much of what we know about the virus, the detection of the virus was done that way. Why do I tell you that? Because you can detect the viral genes, and that doesn't mean you're actually detecting live viable virus. So we know from Ebola and Zika that the viral genes are detectable long after the virus is dead and gone. So we make a big caveat with that. But what we learned from this, from the throat and from the nasopharynx, which I'll show in a second, is that the virus is detectable particularly in the earlier days of the infection, and the genes are detectable for as long as 20 days on the average, but in rare cases are detectable as long as 37 days after. That's the longest I've actually seen virus detectable in the nasopharynx. But remember, that's all done by detection of the genes and not by the viable virus. This is the virus in the nasopharynx, which probably is, in some ways, you might consider the most infectious, even though I recognize that may be an oversimplification. But you can see here how the early days of the infection are where you found the greatest amount of the virus. It's in those early days that the virus is most likely to spread. And we now know from studies that were done in Germany just recently that you can repeat these studies doing cultures of live virus. And if you do that live virus study, you find the same thing. The virus reaches maximum infectivity the day they get sick, and then is infectious, gradually declining up to about a week, up to 8 or 9 days. And probably on the preliminary information we have now, preliminary, because all this is subject to change as we get more information, by the 10th day, the virus is probably gone. We'll wait to see if that gets confirmed. Now, there's another shocking thing that just has been reported. We think that as long as you can detect the virus on day 1 of illness in its highest amount, somewhere before day 1 of the illness, the virus was already infectious. And one investigator, Chinese investigator, and reporting in the journal of Nature Medicine, has suggested that the person who gets the virus is probably infectious at least 2 days before they get sick. And that's a very important consideration to us, because what that tells you is you can spread the virus and you don't even know you have it. And that's why many people, in fact, it looks like the majority of people get the virus, don't know where they got it from. And probably it happens because they were spreading it before they got sick. And in a percentage of cases, we don't actually know how many, some people may get it and never get sick. And we'll talk about that as we go along. Okay, so how do you protect yourself? We know that the virus is contagious. We know it's excreted in the nasopharynx. We know it we spread by droplets, maybe in rare cases by aerosol and certain procedures. So we know there are things you can do to stop it. Most important, maintain your distance. And I have to tell you that when I walk down the street and somebody forgets to do this, I feel like I want to give them a good push. So maintain your distancing, because that's probably the best protection you have. Remember what I told you. Most people, that's a little bit of oversimplification, who actually have the virus probably go through a phase when they don't even know they're infectious. So you pass somebody on the street, they may have the virus and they don't know it. So social distancing, very important. What about masks? Do they help? Yes, not as perfect as you would think. They are particularly effective if you have the disease and you're coughing and you're sneezing and you wear the mask and it's trapping the droplets so they don't go into the environment. That's very effective. But it probably helps if you're wearing a mask as well. The only time it maximizes protection is if the mask is sealed tightly. That's what N95s are supposed to do. They're supposed to give you a seal so that if you suck in and blow out, you can see the mask moving back and forth. But without that seal, you're not maximally protected. No touch, because of the pick up environment. Cough etiquette, cover your mouth when you sneeze, cough, etc. And we try to keep people quarantined during the period of infectivity so they don't spread to others. Why are we doing all this? Because we're trying to delay all of us from acquiring the virus until we can adequately protect ourselves. Because while the majority of us may get it and do well, many of us, particularly older age group, are particularly vulnerable and likely to suffer the worst consequences. So we're trying to diminish the spread until we have adequate means of protecting ourselves, either because of medications or because of the vaccine. Okay, how long do we quarantine? Well, if you're just exposed, 14 days from exposure. If you get sick, I want you to be at least 7 days from the onset of illness and at least 3 days without any fever. And that's, I think that's maximal, but that is the CDC definition. Okay, so in the hospital where we are working with patients who already have this and we put them in isolation rooms, then there's a number of things we do. We know the minimum protection for just being around patients is to protect yourself from droplets. So we wear masks, we wear frequent hand washings, we do eye precautions, and certainly if you can, gloves. We want eye protection, meaning typically a mask, plastic mask that you wear. Some cases just goggles, but they have to protect the eye. And definitely, if you're touching, either gloves or frequent hand washing. If you're actually working with the cases, then we use masks, we use gowns, we use the face shields, and N95 masks. For special procedures like bronchoscopy, where we know we're going to aerosolize the virus, then we also use gowns and gloves, etc. Hand washing becomes important. And if you're dealing with these patients on one-on-one basis, then gloves are always a very reasonable consideration. So what happens when you get sick? Well, most of what we know about people getting sick were the first few cases that enter the hospital. So the description of the illness really was those people who had, for the most part, the worst illnesses. And just now, the last month or so, we're beginning to realize that there is a spectrum of diseases And the original description of the disease was of the worst cases. Probably are a lot of lesser cases that either have very mild symptoms or at least don't recognize them as symptoms at all. But in the beginning, we recognized people because of a set of symptoms. In fact, at the beginning, we didn't even have the test for the virus. So we had to put together a complex of signs and symptoms that we said were typical. So we were diagnosing people on the basis of what their clinical presentation was. And then when we got the test, we could begin testing more people. But even today, we have not been able to test almost everybody to find the mildest of cases. And we're just beginning to get a clue that when we expand the testing, we'll talk about that a little bit more, that there are a lot of people out there who have been infected and who have not recognized it. Whether they've had no symptoms or minor symptoms, can't say, but at least they haven't recognized it. So what are the symptoms that we have recognized? Major ones are, for the sickest patients, fever, cough, and shortness of breath. Oftentimes, they have sore throats, a lot of fatigue. So it depends upon what series you read. May have been influenced somewhat about certain locations, whatever it is. But the hallmark of the disease has particularly been fever, cough, and shortness of breath, because most of the patients that we were treating in the beginning all came with pneumonia. And we know there was a prolonged convalescence, oftentimes with a lot of fatigue, and so the symptoms persisted. There were unique things that were discovered as a part of it. Some people presented with a loss of taste and smell, probably something to do with the virus in the nose blocking the receptors for taste and smell. Not unique to this virus, but certainly was well described. We know there's a rash that seems to be typical of this. Some people get GI symptoms, but those that get diarrhea and vomiting seem to be a fairly small percent. When you see 35, 40% with GI symptoms, oftentimes that meant they lost their appetite for a while or they were a little nauseated. But true GI symptoms of the diarrhea and vomiting seem to be relatively unusual. This is what the chest x-ray looks like. Oddly enough, when you do a chest x-ray on a lot of these people, the initial chest x-ray is pretty normal. This chest x-ray, the upper part of the chest, higher part, is close to normal, where you want to see a lot of black and a little bit of white. You can see the ribs that are there. You can see the heart in the middle. Down in the bottom of the lung, it gets a little dirtier. You get a little more little streaks. Probably those are inflamed bronchi and bronchioles. But the next slide, if you do a CT scan, a CAT scan on the lung, then you find this. Now, when you do a CAT scan, you look at from the feet up. And what you're doing is you're slicing the body from one side to the other. So you go from shoulder to shoulder, hip to hip, looking from the feet up. So if you're looking from the feet up, that means what is on the left hand is actually the right, and what is on the right hand is actually the left. So the circular density on the left side there is probably the dome of the liver. But what I want to point out is where those arrows are, that's where the pneumonia is. And we call that pneumonia ground glass. It looks like, because it's probably a lot of little air pockets that are filled, it looks like a ground glass appearance. And up on the right side of the slide, you can see a round area with a little black dot in the center of it. That's the center of it. That's actually probably the beginning of a cavity that's forming. So you can have chest x-ray that looks pretty good, and then you get a CT scan and you find that they actually have pneumonia. But again, all done at a time when we were finding the worst cases. We do know that there are people who have an unusually significant risk for this. Age seems to be a factor, and that's not unique to this virus. We know that's true of influenza, for example. Cardiovascular disease, hypertension, seems to be a unique factor. And again, we have to sort out what components of that are true risk factors and what aren't. Hypertension has been listed as one. 50% of people who got sick seem to have a history of hypertension. Diabetes, obesity, which I didn't list here. There's another mistake. I see an O that shouldn't be there in the middle of comorbidities. Obesity seems to be another major risk factor for disease and severe disease. So these are not only risk factors for disease, but oftentimes predict which of people are going to be the sickest. Okay. Now, the Chinese, when they reviewed 75,000 cases, said, look, 75% people have mild disease. 25% have people that are sick enough they get admitted to the ICU, and 8% require intubation. 3% require the use of an artificial lung, extracorporeal membrane oxygenator. That's called ECMO. So they were talking about the sickest of the sick. And when they talked about mild disease, oftentimes that would be for you and me a bad cough. Admission to the ICU mean a bad pneumonia. But again, I think we recognize that probably this statistic is biased in the direction of the very sickest patient. But if you do get sick, then not only can you have respiratory problems, which are clearly key, but you can have renal injuries, kidney injury, liver injury, shock, and even cardiac problems all can ensue as part of the course of the disease in the worst cases. We know that if you come in, you get laboratory tests. We know in a percentage of cases, your white cell count is low, leukocyte count, but particularly what's abnormal is that subsection of your white cells. We differentiate into polys, which are the phagocytic cells, and the lymphocytes, which are the more immune cells. In this case, the polys are okay, which are typically the majority of your white cells, but the lymphocytes, the immune cells, drop. And we know that the sickest patients have the greatest drop. So it's a predictor that we almost can use, not quite to that stage, but it's a marker oftentimes that you see in the sickest patients. We know that with any severe disease and pneumonia, you get changes in the liver function tests, which are enzymes made by the liver. We know you get clotting abnormalities. And again, the clotting abnormalities and markers of inflammation, which are ferritin, which is an iron-binding protein, C-reactive protein, and procalcitonin are markers of degree of inflammation. And those oftentimes, again, seem to be highest in patients who are the sickest. And so when we see patients coming to the hospital, we look to see what are their risk factors. When we try to say who is going to have problems dealing with this disease, probably the biggest factor that determines how sick you're going to get are your risk factors. And then after that, a compilation of the clinical appearance and the laboratory findings. We know that the immune system in these patients overreacts. And we know that it overreacts because some of the signals that the immune system produces, like cytokines, of which we have many, interleukin 6, interleukin 6, 10, interferon alpha, rise. And the sicker you are, it seems the higher the levels. So that we know that the body is dealing in some cases with intense inflammation. And we are of the opinion that if that inflammation gets really bad enough, that itself may be deleterious. And I say that in a sense that we know that when these factors get high, that they and of themselves seem to be associated with some damage. And we're thinking of ways some of the treatments that we have actually block the production of some of these factors, thinking that if we control the inflammation, patients will do better. And that we'll have to wait and see if that bears to be true. But right now, that at least is one of the theories. We know that your immune cells, when they overwork like this, oftentimes the numbers drop to lower levels. That's particularly true of what we call the helper cells, which we call CD4, and the CD8 cells, which are cells that are responsible for, in many cases, killing the virus. We know that if we take a little piece of the lung, particularly from people who have died, there's a lot of CD8 cells that predominantly are attacking the virus in the lung. We can see that. And we know the interferon producing CD4 T cells are low. Interferon is one of the body's first natural defenses against viral infection. And we know that in coronaviruses, at least the bad ones, they have mechanisms to block the body from producing interferon initially. And then after the first few days when they blocked it, they let go of the block and the interferon level begins to contribute to the inflammation. So they have ways of manipulating the virus, of manipulating the immune system to their advantage. This is what I wanted to show you about risk factor, why we worry so much about older people. And again, drawn from the sickest of the sick, but of those people who died, largely again, these from China, but this has also been true here, that the highest proportion of deaths occur among people over the age of 75. In China, you can see again, on their cases, again, largely probably among the sicker patients, if you got this disease, call it COVID-19, caused by the SARS-CoV-2, chance of dying from it was 15%. And if you translate that into you bringing that virus home to somebody else, and somebody else gets that virus, then you can see that the chance of somebody in the household, particularly an older couple, dying becomes substantial. So the elderly we consider to be the most vulnerable. So what do we do for treatment? Well, we don't really have a lot of treatment right now. It's mainly what we call supportive care. We give you IVs, we give you oxygen. If you have to be assisted in your breathing, we can put a tube down and put you on a ventilator so the machine breathes for you. We can give you increased concentrations of oxygen. In the worst case, we put you on an artificial lung that literally breathes for you, essentially. It's like a dialysis machine, but instead of the dialyzing the fluid away, in this case, it's putting oxygen into your system. So treatment at this point is not one we're satisfied with. So what are we working on? Well, we're working on antivirals, first and foremost. The one that's subject to the most testing so far is remdesivir, which, as I told you at the very beginning, blocks the enzyme that the virus uses to produce itself. There are many trials now of remdesivir that are ongoing. The first was actually released, was analyzed about a week ago, and now we expect a more complete analysis in the month of May. The results are not out yet. I think there is, in my opinion, reason to be a little optimistic, but I think with all of these things, what's going to be critical is when you get the drug. If you get the drug when you're already in the ICU and on ECMO, then the chance that it's going to help you is less. But if you get it at the right time early on, then I think the drug has a maximal opportunity to help you. There's a second drug that does the same thing, produced in Japan, called favipiravir. We have beginning trials here. There's a lot of hope for that drug as well. And so we'll see what the trials actually produce, but we're anxious for the results before we really know exactly what the benefits that they offer. There are other drugs that we try to have rescued that work in tissue culture. One of them is the hydroxychloroquine. Got a lot of press in the beginning, largely because of a French study that was not very well done, and that has created a lot of confusion. We know these are malarial drugs. They actually they are synthetic quinines, is what they really are. And my memory serves me correctly, they were developed in World War II when we couldn't get quinine. And they work well for many cases of malaria, depending on the type. And they work in tissue culture against the virus. But what we really don't know yet is, do they work in people? And a number of those studies are now ongoing. The drug is available, it's being used, but the studies will be done, I would think, within the next few months, and perhaps sooner, that will give us a better idea of whether they really work, and if they do, when they work, and who they work best in. I told you before, when the virus is copied, it begins by making proteins and sticking them together in a large string that has to be chopped up. And we know that there's an enzyme that does that chopping, and if you block that, you can prevent the virus from reproducing. And that works well in hepatitis, for example. We have tried the drugs that work, same category of drugs that work for AIDS, which are again called protease inhibitors, and HIV. The one that's been tried is an inhibitor, again, of the AIDS virus, a protease, and that does not look like it works in humans. It's tried, people still use it, but the first study looks like it's probably not working, but we're continuing to study it. I told you before about the inflammation and blocking the excretion of some of these cytokines. That doesn't affect the virus, but one thought was, well, maybe while we're worrying about the virus, let's try to control the inflammation. And so we have used a number of inhibitors, or at least 3 that are out now, that are currently being tested, again, as a way of sort of indirectly influencing the course of the disease. Told you before, interferon is a natural antiviral substance produced by the body that the virus blocks from interfering with its production. And so among the things that are being tried is to give interferon produced in the test tube, to give it to humans. So if we give it early enough to patients with a lot of risk factors, we overcome the viral block, and maybe that will help. And now we're also talking about giving antibodies from people who have recovered. Can we take their plasma, and sooner or later their antibodies, and give it to somebody who has just gotten the disease now, in the hopes of preventing it from progressing? So these are the treatments and strategies that we're working on. But what you're all waiting for is, what about vaccines? Are we going to have something to prevent it? And the answer is yes. There are right now something like 35 groups. Actually, I think the last I read, there were 115 potential vaccine candidates available, of which 78 are active. There are actually 5 that are right now in trial. And these are all being tested now to see if they will work against the virus. Why does it take a long time to know if they're going to work? Because first of all, you have to immunize people, and then you have to allow them to be exposed to see if they get infected or not. And you have to compare them to a group of people who don't have the vaccine and see if there's a difference in the infectious rate. So that is a problem for us. But you can see there are 5 vaccines, 2 being tested in the US, 3 being tested actually in China, all relying on slightly different strategies, but all right now in the first phases of the testing. And not only will we look to see whether they are effective, but we will also look to make sure that they are not harmful, which is the other aspect of vaccine testing. So that's where we are today, from our understanding of the virus, to our understanding of how infectious it is, to understanding what it does to people, to what it is that we can do we think alter the course of disease, to what we think we may be able to do to prevent it. So now I think we can answer questions.
Okay, please explain what it means that COVID-19 will mutate.
Well, what it means if it mutates is that something in the genes of that virus will change. Oftentimes, genes are composed of nucleic acid, adenine, thymidine, cytosine, guanine, those types of things. And they are combined into codes. And the right combination for those 2 things will dictate a certain amino acid. So when you go from the gene to producing a protein, the gene dictates what amino acids are going to be placed in the protein. And oftentimes, if one of those nucleic acid gets changed or rerouted somehow, then it codes for a different amino acid. And by changing the amino acids, you can also change the function of that protein. And sometimes it's just a matter of 2 or 3 amino acid changes, and you get something that can't perform a function from something that can. And one of those differences is ability to attach to a human receptor. May just be a matter of several different amino acids.
Next question. Can a person have a positive nasal PCR test and a positive antibody test at the same time?
The answer to that is yes. We know that you can begin to see antibodies on about the 5th day of the illness, but you detect the virus RNA as long as 20 days.
Yes, doctor. Do any of the medications available today to mediate the flu are effective on this particular COVID-19?
That actually was tried. Oseltamivir, which is a Tamiflu, is one of the drugs that was tried. And so far, they have not been found effective.
First question from the emails is, what tests are currently available and where?
The only test that's broadly available now here is the RT-PCR, which is the detection of the viral nucleic acid. And that's now pretty much everywhere. It's almost on every street corner. And that's done with a throat swab, or it's a nasopharyngeal swab. And depending on the nature of the test, you can get answers in a few hours, probably most 24 to 48 hours, gives you the test result. Again, you're not detecting live virus, you're detecting the viral genes. And so we assume there's a correlation between the two. But we use that as a diagnostic test. But remember, that will only be true, will only be a positive test during the phase that you are actively infected, meaning like the phase you are sick. Once you get over it, that goes away and you can never tell. The second test that we're beginning to adopt, I think at UCI, I think we're going to start doing it tomorrow, is the antibody test. And the antibody test will tell you if you have ever been infected. Neither of the tests are perfect. They both have some flaws, but we would like to use the two together. One to tell if you're infected now, the other to tell if you've ever been infected. Presumably, if you've ever been infected, you will have some degree of immunity.
Please describe the timing of IgM and IgG becoming positive.
Now, what I didn't tell you before is from the time you get exposed until the time you get sick is called the incubation period. And that's generally considered to be between 4 and 5 days. So from the day you get sick, you can generally say you got infected about 5 days before. Usually you begin to see the development of antibodies about 5 days into the illness. Somewhere between 5 and 10 days into the illness, you will begin to see antibodies. Those are usually IgM antibodies. That means that when the time you get the antibodies is probably somewhere around a week or so from the time you actually got infected. And then within a few days after the IgM antibodies, usually maybe about a week, 5 days to 7 days, you'll begin to see the long-term antibodies, which we call IgG antibodies. And those should carry the rest of your life.
I have another email question. I hear a lot of people saying they don't understand the intensive shutdown for COVID-19. Since there are many, I hear a lot of people, since many deaths from the flu every year, equivalent to what are so far seen for COVID-19, in other words, 80K in 2008, in 2018, one of our worst years. Thus, the protests in many states, including in our own. What is your response to those people?
My response is, in the average year in the US, we have 35,000 deaths from this virus, from influenza. You know, right now in the world, I think we're close to 200,000 deaths in the world with this. In the US, we're at 25,000 deaths from this virus. And that's in the space basically of about 4 to 6 weeks. And we're not done with the virus. It's still going on. So my suggestion is that this virus can be catastrophic. And if you doubt that for a second, see what's happening in New York, where they can't get enough beds in the hospital. Come and see what it looks like to see a patient who's dying of this disease. So yes, this disease is definitely catastrophic. So I understand the concerns about the necessity of getting people to work. But why would you not want to prevent this if you could be the one this virus is going to kill? Or your family member is going to be one this virus will kill? Because today, whether You believe it or not, this virus is killing people, and it hasn't stopped. And if you look at the statistics in the U.S. And you look at what's happening in California, you know, I think we're killing in the U.S. about 25,000 people a week from this. I better not give you the exact numbers, but whatever it is, there's still people dying from this. And I think the simple precautions that we can take to prevent people from getting it are worth doing, realizing that there are things that will have to be done to get things going again, but they have to be done stepwise, because otherwise we risk pouring fuel on the fire.
Why is aspirin not recommended to use for treatment to treat fever from the coronavirus, or ibuprofen?
I don't know, it's not recommended, but there are two things I would tell you. You know, in children, we have learned that the aspirin is a problem for somebody called Rye syndrome. So we don't use aspirin in children for minor illnesses. We use Tylenol because Rye syndrome is a catastrophic disease in children. Probably is a genetic factor that seems to be set off by the use of aspirin. So that's one reason why we are careful, but that's limited to children largely. The other issue is that, you know, in adults, we really don't fully understand whether or not any of these things are harmful or not, and so we're just being cautious. But I don't actually know there's any reason for not using aspirin. Maybe something that I'm unaware of, but I don't know that there's not a reason for not using it in adults in this situation. And maybe, as I said, that could change tomorrow.
That ends our question period. I want to thank you, Dr. Cesario, for a wonderful and very informative presentation. I also want to thank the almost 80 people that joined us this morning.
And I want to thank you, and I want to thank Jim and Bill for all the help to make this possible. So appreciate all the good effort.
With that said, we will adjourn, and thank you again.